There goes.
Good evening, ladies and gentlemen, friends.
No,
Go on.
further away.
Already, just started, I'm already getting orders from the boss. Welcome to the first session of the fourth year, would you believe our fourth year of navigating the medical system? And I actually gave the very first one three years ago. And Stuart has agreed to join me in presenting the first one this year. Please feel free to take notes. Please feel free to ask questions. If you're going to ask a question, please raise your hand or write it on your little pad. Please do not ask personal questions because the answer to those will be, please ask your local rabbi. The purpose of this entire series is really to educate the lay public as to what is current in medicine and how to get help, and particularly how to avoid trouble from not getting help or from getting the wrong kind of help. And therefore, I always select people who are into evidence-based medicine. Now that means that there are papers that have been written in reliable journals to defend what we're going to do. Stuff that has not been approved by reliable journals is not going to be presented at these things because they're all hearsay and they're anecdotal and they're not good. So now, you're going to learn from what I have to say that not everything that is in reliable journals stays true forever. Things have changed significantly. Now, we have great sessions coming up. We finally got a psychiatrist, thank Robert Barris, to present one on psychiatry issues in a month. We have one on women's health. We have one on dementia. We want to have one on dental health. We're going to have a transplant session with people from Project Renewal, which you may or may not be familiar with. It's a kidney transplant from organization. We're going to have one on vascular studies. We're going to have one on motion disorders, and finally another session on arthritis, which we had last year with the same people. Before we start, I want to say medicine has significantly changed over the last 50 years, and I'm going to tell a 50-year-old joke with a new modification. I want to thank all of you for missing the beginning of the Met game for coming here. 50 years ago, when the Mets were terrible, there was a...
Let's go Mets.
Go! Let's go. 50, for those of you who don't know, Mets in medicine used to mean, and still does mean, metastases. Metastases are very, very bad things. And the old joke went, what's the difference between Shea Stadium, not Citi Field, Shea Stadium, and Sloan Kettering? Anybody have the answer? The answer was, at Sloan Kettering, the Mets always win. Baruch Hashem, we have changed medicine a lot, and the Mets now lose, not often enough, but very often at Sloan Kettering, and the Mets win at Citi Field. Things have changed that way. Medicine has changed quite a bit. Okay, I'm going to give one example from my first week. I graduated medical school 55 years ago. I'm not I went to Einstein, and the very first week, I only remember two things from the first week of medical school. And the second one was the first psych session we had. And they presented to us a man with ulcers, plain ordinary ulcers. Show you how things have changed in this time. The psychiatrist presenting the case, and remember, we were fresh medical students, we didn't know any better, swore that this man's ulcers were 100% up here, not in the stomach, not anywhere else. He swore this was 100% psychiatric disease. Well, things have changed. We learned, shortly thereafter that ulcers were due to acid in your stomach. And indeed, everybody got on the acid bandwagon and they invented medications that got rid of acid. Things like Tagamet, which was the first one, Prilosec, which was the first of its new class. And all of a sudden, people with ulcers got better, although they continued to get them. Then, about 20 years ago, there was a paper, I actually read the original paper, I couldn't believe it. These guys came out and said ulcers are due to a bacteria in your stomach. What? Bacteria in your stomach? It's got to be up here. It's got to be from the acid. No, ulcers are due to acid in your stomach. And as we discovered how to treat this H. pylori bacteria and get rid of it, ulcers have disappeared. When I was a student and a resident, people were getting ulcer surgery, jeden Montag and Donnerstag. The surgical floors were full of people getting their stomachs cut open and acid things and their nerves cut and so on to prevent recurrence of the ulcers and the bleeding that came with them. Surgeons these days don't know how to operate on people with ulcers. It just isn't enough to practice on. It's changed completely. Just when they figured out which might be the best kind of surgery for ulcers, ulcers were getting better. It's amazing, and it's probably the most radical example of something that's gone to something very serious and common with a theory of how it started, to something that is 100% treatable, or 99.9999% treatable. Surgery isn't needed anymore, and it's wonderful. Well, I'll give you a couple of other examples of things that have changed. When I was in medical school and I was a resident, we weren't using mammograms. Actually, they were being done a little bit, but they weren't being done terribly well. And the only way you found out you had breast cancer is if you felt a lump in your breast, or your doctor felt a lump in your breast, and you went to the doctor, and the surgeon said to you, okay, we're going to put you to sleep, and we're going to do a biopsy. And while you're sleeping and you have no idea what we're going to do, if the biopsy is positive, we're going to cut off your breast and take out all the lymph nodes and deform you forever to try to treat this thing. And if there was any evidence of spreading, there was no chemotherapy at all. There was radiation, and radiation to an area that's already had a radical mastectomy is a horrible kind of thing. Baruch Hashem, this is rarely done anymore. And right now, we get mammograms. I predict that in the future, we have to talk about the future a little bit, mammograms are going to be probably abandoned. And in fact, they came out with, I heard this on the radio today on the way here, that mammograms are being recommended to start only at age 45, and that they should be done no more than every other year in women over 65. Now, the recommendations came from a task force. What is a task force? I'll tell you in a moment. And they said, you know, if you want to have more often, you can. We have task force now. What is a task force? These are big mavens of various kinds that decide what is the best way to look for, to screen for, to treat any significant major disease. There are task forces for cholesterol, there are task forces for high blood pressure, there are task forces for diabetes, and the recommendations change. Every year or two, they come out with new recommendations, because not everything we do is written in stone. Your doctor should know what the recommendations of the task forces are now, and you can look them up online. Just look up task force for X, Y, or Z, and there it is. And when you go to your doctor with a particular problem, look up what the task force says. If he's disagreeing with them, talk to him about it. Another one, prostate enlargement. As you know, prostate, we have to deal with the men also here. Prostate enlargement is very common. What happened in the good old days? Well, you have a large prostate. They did an x-ray on you called an intravenous pyelogram, which was A, dangerous, and B, not very productive. We've got a radiologist here. And then the urologist that you went to see took a thing called a cystoscope and shoved it into you and said you need an operation. And then you had an operation, and you'd be in the hospital for several days, and if you walked onto any urology floor back in those days, you'd see men walking around with little shopping bags in which they had urine bags attached to a catheter following their surgery. And you could tell what kind of man you were dealing with to see whether a shopping bag was from Wallbounds, from Aaron's, from Lord & Taylor, or whatever. But we don't see that anymore. You don't see men in the hospital having prostate surgery. For that matter, you don't see a lot of things in the hospital anymore. I'm going to talk about imaging for a moment now. Shut your ears, please. Back in those days, we had plain x-rays, pretty much, and also stuff where you stuck dye in, like an IVP, or something called an intravenous cholangiogram for gallstones, all of which required sticking a dye into you, to which many people are allergic, and some people got kidney trouble from them. What do we have now? Well, they came along, and mammography's come along, and sonography's come along, and CAT scans have come along, and MRIs have come along, and amazingly, we can do all these things, quote, non-invasively, end quote, with very little risk at all. I sort of think that in the future, somebody's going to come along with imaging stuff that is going to do a good enough biopsy to tell whether something you're looking at is like a nodule in your lung, to see whether something is malignant or not without having to stick a needle in there to find that out. The problem with imaging, it's been abused. With certain places you go to with a headache, you will get imaged with an MRI, whether or not you need it or not. That comes down to money. In the United States, there are many more MRI machines than there are in any other place in the world. I forgot, I had the numbers written down when I left them home. Lab tests. Lab tests, when I was in medical school, we had maybe 15 chemistry tests to do. We couldn't do liver tests to speak of, except the bilirubin. We couldn't do anything fancy. We had no good test to decide whether somebody had a heart attack or not. And all of a sudden, they came up with automated machines. And automated machines, you put a little drop of blood in there like that, they'll tell you pretty much everything you really want to know in a basic kind of situation without looking for special stuff. Surgery. When I was in medical school, the surgical floors were full of people having their gallbladders taken out, waiting to recover, and to have their ulcers done, and to have their recovering from their colon surgery, or whatever it was for. Somebody came along and said, hey, you know, we can do laparoscopic surgery. We can stick some instruments into you and take out what's bad, sew up what's bad, and so on. Surgical floors are empty now, relatively to what they were. Hospitals are gone. If you look around this community, 4 or 5 hospitals have closed within 5 miles of where we are. St. Joseph's, Mary Immaculate, Parkway, St. John's, and there was one other one. But why? What? Okay. So, you know, why are they closed? Because people don't have surgery in hospitals anymore. Or if they have it, they're out in a day or two. Cataracts. My mother, Aliyah Shalom, had 2 cataracts done. I was already an attending. This was in the 70s. She had her cataracts done one at a time. They made her stay in bed in the hospital for 5 or 6 days with each one of them in bed without getting out of bed after cataract surgery. Got these thick lenses and so on when she got done. Now, you have cataract surgery, you go to the doctor's office, he takes it out in 5 minutes, you go home that day, and you never use the hospital. That takes care of a lot of hospital beds. Endoscopy, when you look in the stomach or you look up the colon, that was just beginning when I was in school. Now, people can do real big operations, including a new one which is coming out now, repairing hiatus hernias endoscopically. Adult immunizations. I happen to have the miserable privilege of being an intern in Baltimore when we had the very last mini polio epidemic in this country. Baltimore had 97 cases of polio in 1960-61, and I personally took care of the ones who were sick, including people with iron lungs and so on. Who sees polio anymore? I mean, it may be totally eradicated.
Pakistan.
Third world, they still some in third world.
Bringing it to Europe.
Okay, we have vaccines now for flu, and I recommend that each one of you gets a flu shot. We have immunizations for pneumonia, and I recommend anybody over 60 get a pneumonia shot. We have immunizations for shingles, we have immunizations for kids for hepatitis and meningitis and so on. They didn't exist in those days. Dialysis. You had kidney disease, it was sort of an easy way to die. You sort of basically faded away without any pain with chronic kidney disease, but nothing could be done about it. Now we have dialysis and we have transplants. I suspect that in the near future that we will have fake kidneys that will work just as well as anything. Terrible arthritis. You had terrible arthritis, you suffered. We didn't even have anything but aspirin or Tylenol to treat them. Somebody came along and discovered non-steroidal things like Advil and ibuprofen and naproxen and so on. They help a lot of people, but right now, the third most commonly done operation in this country, next to cataracts, and what's number two?
Knee replacement?
Huh?
Knee replacements?
No, that's number three. And hip replacement's number four. Number two actually surprises carpal tunnel syndrome, carpal tunnel surgery.
But I heard it doesn't always work.
I can guarantee you that. Okay, diabetes. Back in those days, we had insulin. You had to take shots every day, even if you were type 2 diabetic, and you just had an elevated blood sugar and so on. And people did not do well with diabetes. Now, as you know, we have all kinds of treatments for it. High cholesterol. We had no treatment for that except diet. And frankly, when I was in medical school, I had one professor who was a pioneer of lipid studies, and he was having a hard time convincing people that high cholesterol and high triglycerides were not good for you. By the time I became a resident, it became common, we had no way to treat it. My favorite, psychiatry. I'm going to leave some of this for Robert for next month. When I went to medical school, everything in psychiatry was Freudian. That means it was all in your head, pardon the expression, and nothing could be done to help it. I went to a lecture, Grand Rounds at Hopkins when I was an intern, and a guy got up who was the new chairman of the psych department, and he said, hey guys, all of you, from now on, all psych disease will be treated with medications. We just have to discover them. And I sat there and I said, I don't know what you're talking about. Well, he did. He really did. And now, all psych diseases are treated with medication. Except I heard another one on CBS coming up tonight. They did a study saying that, in schizophrenics at least, the medication alone doesn't help, that you need cognitive therapy, and the combination works better with low-dose medication and cognitive therapy. I'll say a couple of words about insurance in the old days. In the old days, if you had insurance, it was aimed at hospital stays. If you had to get outpatient treatment, only a couple of insurance companies, Blue Cross was one of them, paid for anything as an outpatient. What you do though? Huh? They still pay very little. What you did was you went to the doctor and you paid him, whatever you paid him, $3, $5, whatever, and he filled out a form for you and you applied to your insurance company and they sent you back something, whatever it was. But it was nothing like it was. If you went to the hospital, they played pretty well. And maybe in those days you had to go to the hospital more often. Page 2. Who ever heard of probiotics in those days? That's a future thing. My mother used to make yogurt at home. And she said, this is good for your health. And I hated it because it was sourer than the current yogurt. But the reality is, yogurt is the original probiotic. Probiotics really help you. We just have to get more studies done to say which of the probiotics is better and which are better for certain things. But I predict in the next 10 years, you will find studies saying certain probiotics will help certain things and other probiotics will help other things. That doesn't mean go out and buy every probiotic that's around, because some of them are going to be expensive and some of them aren't going to help you, and they may counteract each other. They are bacteria for the most part. This goes back to 1905. In 1905, a Russian scientist named Mechnikov, came out, and he won the Nobel Prize, not for this, but for other stuff, came out and said, all your health depends on the bacteria in your intestine. And it took a long time for people to begin to realize that at least some of your health depends on the bacteria in your intestine. There are, as you know, billions and trillions of them. Antibiotics. We had 5 antibiotics when I went to school. Two of them aren't used anymore because they're toxic or useless, and they've been improved upon. And there have, as you know, there are many antibiotics out there. They are the most abused of all medications. Too many people get antibiotics for sore throats or colds that they don't need, and that's why the bugs out there are not getting responses to the antibiotics that your doctor may give you. Remember, if most things didn't get better by themselves, oh, another guest. If most things didn't get better by themselves, with the help of Hashem, none of us would be here, and none of our parents or ancestors would have been here. Generic medications. There were no generic medications back in those days. There weren't that many medications. Thanks to the patent laws, we get generic medications, and most of them, except the shaky ones are the psychiatric medications, but most of them are good, but not all of them. But generic medications didn't exist. So if you had to go buy something as simple as penicillin, it would cost you the equivalent of $50 to $100 in our current money just to buy penicillin for a strep throat. We have them now, and we should appreciate them. Now, I'm going to give you one very, very good bit of advice in terms of generic medication and chain stores. Chain drugstores are in business to make a profit, as you know. It happened today with a couple of skin creams for a patient. It's happened with Ambien. It's happened with a couple of generic psychiatric drugs. It's happened with a couple of generic other drugs. People go to the chain store, and this has happened with CVS's and Walgreens and Duane Reade's and Rite Aid's, all of them. People go there with a prescription that they've got to give you one specific example. A patient of mine had been taking Ambien for years, the generic, and she used to have a $10 copay. She went there, and they said, your copay's changed, it's now $60. She said, what? Yeah, $60. She called me, sort of upset about the whole thing, and she said, what's this? And I said, I'll call you back in 5 minutes. I had some time at the time. I called my local private drugstore, and I said, Joe, what would you charge this lady for 30 Ambiens or Zolpidem? He said, $15, $20, whatever, which was her old copay. These things cost Rite Aid a nickel or a dime or a quarter, maybe, if that much. They are all out to get you to buy what they want to sell you. And they are watching you like Big Brother. The drug companies call me, send me the things, your patient's not taking this, he is taking that, he's taking this and that and so on. I strongly recommend that you go to one pharmacy, and I strongly recommend you find a private pharmacy to go to and deal with them rather than working with the big chains. It's going to get worse. Okay. Now, just a few more things we're going to talk about. Coronary disease. When you had a heart attack back in those days, you went to the hospital, they put you in bed for 3 weeks, and they let you get up very slowly and said you can't work for 6 months. Over the course of years, the President Eisenhower had a heart attack around that time, and his doctor was a man named Samuel Levine, not Levine, Levine, spelled Levine. He was a big professor up in Boston, and he came out with the theory that people with heart attacks should get out of bed quickly to avoid complications. And everybody thought he was nuts because the dogma said you gotta lie in bed for 3 weeks. Well, you know what happens now? First they developed ways of ballooning your coronary. Now they have stents to put into your coronaries. We have diets that people should watch. We have definite evidence that if you have risk factors, particularly high cholesterol, you should treat them aggressively, and it really works. And coronary diseases have changed significantly. Heart valves. If you had a bad heart valve back in those days, you died. That's it. Eventually, it just wouldn't work anymore. Back in the 60s, they started to do heart valve surgery. They cut your chest open. They put a new valve in, and usually an artificial valve, until the Israelis came along and said, no, we don't need artificial valves. We use, you should pardon the expression, porcine valves. Now we use bovine valves, sheep valves, more commonly. And the surgeon would go in and do that. what's been happening over the last few years is we've had transaortic valve replacement, TAVR. You'll hear that eponym in the future, TAVR. People have been for the last few years replacing valves by putting a thing in your groin through the artery, putting the valve through there, taking out the old one, putting in a new one, and the results at this point are not quite as good as open surgery, but they're getting there, and there are a lot of people who can't tolerate open surgery. And that's the way it's going to be in the future. We will do transaortic valve replacement for everything, or most of the time. Never say 100%. Okay. Now, when I went to medical school, they told us about all the diseases in the world, and we had to know about everything. You want to say anything? They taught us about all the wonderful things that you could get, and they gave us a list, and they went through pathology, and they showed us the slides, and then we had gross autopsies and everything like that, and guess what? In medical school, I'll start with carpal tunnel. I mean, carpal tunnel syndrome, which is real and obvious, didn't exist in the medical literature at that time. It just wasn't there. HIV, obviously, you know, HIV started in the 80s. It was called different things at first, gay bowel syndrome, autoimmune deficiency syndrome was the official name. But we had no clue. We would see people with HIV, had no clue as to what was wrong with them. C. diff, that's the stuff that you get from antibiotic-associated diarrhea. That used to kill people. Now we can treat it. There are many ways to treat it, but one of the problems with taking antibiotics is that people get this C. diff infection. I do remember in medical school, you can't forget things like this. It was a winter Saturday night, and one of my patients had just had his gallbladder taken out, and he was on antibiotics, and he was sitting in the lounge. We had no TVs in those days. He was sitting in the lounge listening to QXR. Why was he listening to QXR? Because his son was a member of the WQXR string quartet. True story. I can't mention his name. Anyway, right in the middle of the concert on the radio, I got terrible diarrhea. And he ran into the bathroom, and he was on antibiotics, and he came that close to dying. Fortunately, he got bailed out. We had no clue as to what was wrong with him. It was called antibiotic-associated diarrhea. Somebody came along and said this is due to a bug called C. diff, and sure enough, it's treated. Is there anybody here who ever heard of autism before the year 1970?
No.
Before 1970?
Brother?
Was he told that he had that in 1970? What do they call it?
Oh, okay, so,
Okay.
maybe
It wasn't a syndrome. We never learned about it in medical school. I mean, you know, they came up with all kinds of names for it, but something called polymyalgia, which is an arthritic disease. That was described in 1938 by some German guy, and disappeared until the 70s, when all of a sudden, you know, it came back. It's a muscle disease, gives you muscle aches. Fibromyalgia, that's a new one, if you think it is a real disease, but nobody described that until the 90s. And then there are diseases that, Ebola, West Nile, basically, nobody ever heard of them. Whether they existed in Africa, we don't know. But with global travel, a lot of these things are going to get around. And then there are the drugs, the diseases that are pushed by drug companies, and they make them up. And I'll tell you right now, you see a lot of these ads on TV for this or for that. Restless leg syndrome. What's that? You shake your legs a little bit at night, you don't sleep too well. The reason that came into existence as a medical diagnosis is because these guys came up with a new drug. And they figured out it would help this particular problem. Not that anybody was ever complaining about it. And so we got this TV ad campaign, restless leg syndrome, if you have it. You know, whatever, take this medication. You all see Cialis ads on TV and Viagra ads on TV. Let me tell you, you know, I don't know if it's because nobody talked about it in those days or whether it didn't exist as often or maybe people died younger. But all these sexual disorders that you see on TV, most of them, nobody complained to me about them back in those days. But people are not embarrassed now because there's a way to treat it. And the best one of all is the one thing that absolutely TV has turned into an epidemic is GERD. You know, everybody here has heartburn. And when I was a student and I was a resident, you got heartburn, take some Maaloxone. And people took Maaloxone and they did fine. And all of a sudden they came up with the PPIs and the H2RAs, the medications to treat acid. And GERD is now so popular, you can buy the stuff over the counter. And Prilosec is probably the most used drug in the country at this point. I'm going to pause right now because I just want to let you know things significantly have changed. I'd like to some questions, if anybody has any questions to ask, please. Marcia?
Have they ever proved that allergy shots are effective?
Yes. Allergy shots, there have been a couple of studies showing that allergy shots are effective. They are not effective forever. They're expensive. They have a risk to them, and so on. And because of the development of better antihistamines, they're being used less often than they were before. But they truly are effective in a controlled situation, and so on. But it takes forever, and so on. There are problems with it. Sandy?
No. You made it sound like GERD is a new phenomenon just because suddenly people are paying attention to it or paying attention to heartburn. My understanding is that the eating habits of Americans continue to go down the tube. We're eating junk, we're eating too much, and that is causing more heartburn and or GERD than used to be. And the incidence of esophageal cancer had been increasing also as a result of that. And the focus on GERD medicines and PPIs and all that is in reaction to the esophageal cancer that was being caused by it.
Okay, I'll get into that in more detail. First of all, there is something called Barrett's esophagus, which is a precancerous condition which should be followed very careful in people who have significant heartburn. And people were getting esophageal cancer then. The teaching at the time was esophageal cancer was, and still is actually, most common in people who both smoke and drink. And it's significantly much higher in those people. People get older and the incidence of esophageal CA is increasing because of that, perhaps. When I was in school and when I was a resident, we were taught to tell people who had GERD not to eat, not to drink orange juice, not to eat this, not to eat spicy foods and so on. That has been controlled and studied and is probably not true. I'm not talking junk food, I'm talking about junk food, no study that I am aware of.
And overeating.
Overeating, definitely, yeah.
Wow.
Overeating's bad for you,
Besides that.
but for a lot of reasons. Which one of you, I mean, don't go home and have a fight.
I'm first. Getting back to allergies, thank you for the trigger on that. They're saying that they're saying that now to give children at an earlier age peanuts and other things that may be allergic later on in years, but bringing it into the child's diet earlier so that the allergy will. What is the consensus on that?
Well, that's new information. I mean, I can only speak as because I'm not a pediatrician. I can only speak as a Zadie, and Rebecca will tell you that over the years of having her kids, first they could eat everything, and then they could eat nothing, and they could have nothing but milk for a year, pretty much, and then all of a sudden now they're eating everything by the time they're 5 months old. Is that correct? Pretty much. And there is a study that's showing that by giving kids allergens like peanuts and other things that cause allergies early might decrease the incidence. It's not science yet, full science yet.
So it's true that medicine and doctors are dealing with arts and sciences.
There's no question about it. You know, and a lot of things that were dogma when I was a student are not dogma. They're absolutely wrong.
Thank you.
I don't know if this is for you or for Stuart, but, if you go to the doctor, right, all of a sudden, a few weeks later, a few months later, you get a bill. You have a copay, whatever the copay is, right? You say, oh, it's $20 copay, whatever it is, right? 2 months later, a month later, you get another bill for like $200 or $500. I don't know if it's a Stuart question or that's your question.
We both can answer it, though.
I mean, you thought you were covered, and all of a sudden,
Well, that is the story of my life, actually, those kinds of stories. And it all depends on your plan and the condition, the treatment, and how the doctor coded, or the facility, how they coded the treatment. And sometimes there's often, oh, hello. There's often a,
selfie always.
I don't know if this is your particular case, but there's a classic problem when you go to a physician who's based in a hospital. Sometimes the office visit is one copay, but then any other tests that are done, normally in a private office in a non-hospital setting, no other tests would be added to your costs. But in a hospital setting, you might get extra costs associated with it if you're visiting a doctor there. I don't know if that was the situation.
Exactly, it was a private office after this happened.
Okay, so, and even then, sometimes today, with the way physicians' practices are evolving, they're still often connected to a hospital, and that could still have part of the,
Whose fault, is that the doctor's fault? I mean, whose fault is it? I mean, you don't want to go to the doctor and find, whatever it is, if I get $1,000 bill. You think you're covered.
you know, you have to start with the insurance company. You need to see the EOB, the explanation of benefits, thank you. And from there, that's how you have to kind of unravel the thread backwards. Now, another point which Mel metaphorically kicked me in the leg about, but showed me in right, is that there's a concept called balance billing. Now, I trust this wasn't your situation, but you can sometimes go out of network and not realize
No,
it.
it was in network.
Okay, well, but sometimes the doctor didn't code it right. You ask me, who's at fault for these things? The system is so unclear sometimes, and it's so fluid, and the codes, they've just instituted a new set of codes for doctors. Those of us in doctors' offices know that there's a whole new set, a whole new book. The Wall Street Journal wrote a very cute, sad spoof on the fact that being hit by a duck is now a code. And you have to code it properly. And then it's being hit by a duck and then falling down afterwards and hitting your head on a pole, that's another code, So that makes the system so complicated. So I would say 8 out of 10 times, when I unravel a problem like that, it's because a code was not understood. Maybe a person in an office wasn't familiar with the codes and miscoded. So it happened to me once. I got a ticket on my lawn there was someone dumped garbage on the side of my house, and I got a $50 ticket, and I wasn't going to fight that ticket, so I just paid it. And then a few weeks later, I got a balance bill for $4,950.
Oh my God.
Why? Because when they posted my check, they said it was actually, the ticket was for a dead animal, not left on the side of the curb, not some other material that had. So that one I disputed, but again, it's the same story, that miscoding is, I find, frequently a big problem, and that could be what happened. But balance billing is another problem, depending on the agreement. You may have had a deductible that you weren't aware of. You have to be knowledgeable about your plan benefits. Are there deductibles in those plans? Is there co-insurance after you've met your deductible? And
Co-insurance, I've never figured that.
Who knows any of these things?
Now
They
again.
should know. I don't know what these things are. I mean,
so
yes, it's copay.
that's it.
$25 is copay. I mean, you think $25, you pay $25.
Right. So that opens up the bigger story, and I am prepared for that story, which is what is the trend in health insurance coverage today? And that's why the thing is, Mel's presentation was so much more entertaining than mine is going to be.
More.
And he's got more, and don't let me speak too long, because whatever I say, it's not going to make anyone particularly happy. I'm the harbinger of bad news when it comes to that. I'm trying to be more positive, but it's really hard when you're talking about health insurance and talking about health care. And I'm not even critical. I'm not an opponent necessarily of our overall healthcare system, but still, no matter what you say, it's terrible. And I like, in order for me to get through my day, I say that my business, we're graded on a very steep curve. And if you get an 80, that's an A. You know, an A plus, if you get an 80. In other words, 20% is gonna go wrong, and you gotta tolerate that, because that's what it is. And there's balance billing, and there's complaints about issues like that. So it's really, I think the consumer has to get used to the idea. Not so much that there are mistakes and errors. I think those things will slowly clear up. But more importantly, what Chaya said, that the trend for the consumer today is that you are being asked and will continue to be asked to share more of the upfront costs. And that's even with the premiums that you're paying upfront. That is the way the system is evolving, and that's the way it would evolve whether or not there was healthcare reform with the present administration, or whether there was. I mean, that cost-sharing process began 10 years ago or more, and it's continuing at a pretty elevated pace. So plans today, January 1st is a big watershed again for New York at least, and for most of the country. There are several plan changes. A company went out of business, Health Republic, you may be aware, has gone out of business, so that's reducing the choices that New York consumers have for their health insurance. New York employers and New York individuals, they have fewer choices today because of that consolidation. And even within the existing companies, Oxford, Empire, Aetna, Emblem, HIP, Cigna, it's a little different story with Cigna, but they're generally narrowing their choices. So you won't have as many choices, and the choices that are there are going to be increasing in cost for an employer, and at the same time, if you're in an employer plan, and also at the same time, going to ask you to potentially have more expense out of pocket. So that could be also part of what you're dealing with and you may not be aware of. In order for me to answer your question, really in short, I have to see your benefit summary, and I have to see the explanation of benefits that you got for that pay. Not the bill from the provider, but what the insurance company said was their ruling on that claim before the provider, or at some point before or after the provider issued the bill. And that's how it has to be. It has to be tied together, and you have to see what they say. You got to sort of rule out all the mistakes, and then come up with, well, what should have happened? And then accept the fact that probably what should have happened is that you have out-of-pocket expense. Because that's what is happening. I wish, that's why the nature of my work is basically negative. So, I'm trying to be positive about it, but no one else is laughing. I'm laughing once in a while, but no one else is laughing. So that makes it a little bit difficult. And I see a question.
Can I attempt to answer Howie's question?
Please.
Very often, say you have a surgeon, he's a preferred provider, and the insurance company covers that surgery very nicely.
Mm-hmm.
Then a couple weeks later, you get a bill from
Anesthesiologist. Right.
Who's not in
There's a law now in New York State. There's a law in New York State that is going into effect, if it hasn't already, maybe by January 1. There's a law that will prevent that from happening. It happened to me too. I was on a table, I was in my underwear, and the doctors, I wasn't about to ask him what insurance he takes. I assumed that my doctor, my recommending physician who suggested the surgery had checked all that out. Well, I don't blame the doctor either. No anesthesiologists for a while were in coverage. There are very few, and anesthesiologists in the audience will maybe correct me, but there was a time when very few of them, or many of them, were not in networks. And what ended up happening is you have a battle back and forth, and then you handle with them, and that's what I would have to tell clients. You're going to have to do a little handling, and then at least get the in-network covered, and then you finally settle it for like 40% of what they really wanted.
And get a payment.
sometimes.
But not anymore. There's a law now in place.
Is it in place?
I'm almost positive it's in place. Yes, Mark is helping me out. Yes,
Sometimes it's as simple as calling up accounts receivable at the hospital and say,
right.
hey,
Lay
just
off.
charge me money. The doctor didn't charge, but the concierge is.
Right.
So the people who run the accounts receivable say, oh, you didn't know that he wasn't preferred insurance?
How could you know?
Well, okay, you didn't know. One more bill.
Have a nice
The
day.
anesthesia
Oh, I wish.
people be-
Yes, it happens.
Yeah, but wouldn't the anesthesia people have their own billing?
No.
Sometimes?
The hospital.
Sometimes, yes.
It depends. You could have procedures in office though.
Work in a hospital.
A colonoscopy isn't in the hospital
That's right,
necessarily. It's in the office.
colonoscopies are not done in the hospital.
So-
I can just tell you, I went to a booth for ER, and they told me this booth for ER, that no ER doctor or booth takes insurance.
They don't.
You're an ER,
Mel might have some insight into that. May I step back a second and just make a general statement? That the trend today, aside from the fact that there is more of a tendency to impose potential costs on the consumer, the trend is that the responsibility is with the consumer to make sure you have maximized all the benefits that you have in your benefit plan with your employer, or if you're an individual plan. What do I mean by that? It means that you really have to know your benefit summary, and you really even have to make sure that when you're dealing with a surgery or some other type of pre-authorization or potentially pre-authorized procedure or medication, you've got to call the insurance company and make sure that it's been authorized.
Pick up the phone.
Right.
That's true, and you know what? These days, sometimes, the insurance company, one call you make says one thing and the next call says another thing. I deal with that all the time. But you really do have to go and try to base it off your benefit summary. And the government designed something called a summary of benefits and coverage. It's an 8-page document. It's not so easy to follow, but at least it spells out much of the benefits. It's not the certificate of coverage, which is an 80-page document, but it's at least a summary of your benefits, and that's the starting point. You must have that. And as an employee, if you're on an employer plan, and for that matter in any plan, it's the law that you're entitled to that benefit summary. You have to have it. And I'm just trying to raise your consciousness that you can't just assume that your health insurance is taking care of you. You have to take care of you. You have to take care of how your health insurance is implemented. Don't assume that it's going to be done by someone else, because what's going to happen is you will get a bill somewhere along the line, and it'll be too late. You'll have had the procedure before the authorization or whatever it may be. So you just have to be vigilant at every step. Yes.
I have a very strange question.
I love strange questions.
Okay, what happens in a case where a doctor ordered a blood test, by the time the results came back,
Wrong
the
lab.
doctor's gone,
Oh.
vanished within there. And I'm getting a bill from an insurance company of $1,000, when it doesn't even make sense, I'm covered for lab.
Maybe they sent
My
it to a
result
lab.
is not here. It's not
Maybe
there.
they made a
It's gone.
mistake. It could
Wait,
be
but
a call.
you did have this test, or you didn't have it? Is it a real?
He filled out for, he did a blood test.
Mhm.
He came back to me, I never got the results because he don't, he gave it to the vanish, we don't know what happened.
What happened? What is you're still getting billed for that?
Yeah,
Well, you got to be in touch with your insurance company. You got to call them and tell them, it was a
I'm not
miss.
paying for Dave.
They'll ruin your credit rating.
And they'll go into collections, and then you're in big trouble.
There are appeals, and there's a process of written appeal that you need to go through.
You
It's
can-
a little too specific. It's hard for me to answer just.
If you're not happy with what the insurance company says, you can call the state insurance fund, and I guarantee you they will correct it for
You
you.
want us to report them?
Absolutely, why not?
We have a doctor.
Metro car to get down the subway. I have kind of an interesting perspective. I've only been in medicine for about 15 years now, but I'm a radiologist. I'm a full-time employee. I am not involved in billing, but I basically see what goes through and what goes through people's minds. First of all, the role, the changing role of the physician and the patient over the years. Again, a long time ago, your doctor told you, we're going to cut your heart out, turn it inside out, put it back in your chest upside down.
You'll be okay.
And come in, and the patient would go, what time should I be there? What time should I be there? But the thing is now, as we say, CAT scans, I'm a radiologist, CAT scans have replaced antibiotics as the things that patients want before they will leave. Of so much of medicine, and I see this in radiology every single day, so much of medicine is driven by, first of all, fear of getting sued, which you haven't, and second of all, you have what the patient wants. And a lot of times it's easier to give the patient what they want. The only perspective in talking to people that, for example, kidney stones, this makes me absolutely crazy. People come into the emergency room and they have a kidney stone. So what happens, what are the two things you could do? You're worried about, with a kidney stone, you're worried about pressure on the kidney. So you could do an ultrasound, which does not involve radiation, and if the patient still has pain, see if the stone passes. However, the fastest thing to do is a CAT scan. So what you do a CAT scan. Why do a CAT scan? You have the answer. CAT scan takes 20 seconds. The radiologist reads it, who's there within 5 minutes, calls the emergency room, and will tell the patient, you have a stone, the stone is small enough, it looks like it's going to pass. And if it's a bigger stone, then, but I have patients that are in their 30s that have had 12 to 15 CAT scans. Because every time you come into the emergency room, I get a CAT scan. And the same thing with any form of trauma. Any form of trauma. If you have a car accident and everybody wants to sue, everybody wants x-rays. And the first thing you do, no matter what the doctor says, and they do x-rays, if anybody's been in a car accident, the first thing they do x-rays of the neck, they do x-rays of the back. I have read thousands, I read probably thousands and thousands of cases in a patient with no neurological deficits that can move their arms and legs. I saw one small broken bone in the back. The problem now, and they're starting to track radiation exposure, that's going to be the next thing, is that young people in general, are being scanned because it takes 10 minutes, you're out, and that's basically it. The only point, and so many other tests that are simply run because, and you call up and you say there's nothing wrong, and the doctor says, oh, I knew, I just wanted to make sure. So the only point is that there are a lot of pressures on the doctors. I'm not saying the old paternalistic or whatever, but the point is that the way things are now, from a legal aspect and just in terms of being a nice guy, if you say no to a patient, they're going to go someplace. They'll keep going until they find something. It's true of narcotics. There's now a state registry for narcotics, so that every time a physician writes for narcotics, it goes into a central registry. So if the patient goes, and we see this all the time where patients come in, they have a CAT scan, there's nothing wrong, and the patient is drug seeking, which is not. So the only point being is that most of the doctors, the vast doctors that I know, they really are interested in what's best for you. I know it sounds corny or whatever like that, but the truth of the matter is, if your doctor says, I really don't think you need to test, and the patient says, well, I just want to make sure, it is a tremendous drain on the entire system. It's a waste. Unfortunately, a lot of the stuff, MRIs of the back, in certain cases, they're very good.
But Mark, what's happening is that plans today are putting all of those things into the deductibles, into the coinsurance. So there is a little bit of a disincentive for people, even though people don't care.
The other thing that I think that you really didn't touch on is the rise of, quote, concierge medicine. Mm-hmm. Concierge medicine, from what I can see of it, is not doctors, like going out to the Hamptons and address that. Concierge medicine is basically, people are reasonable and it's growing, where, you come to me, and one of the guys I know is a neurologist, and dropped all plans and says, I charge $75 to see a patient. If I have to spend an hour with the patient, I'll spend an hour with the patient. If it's whatever the point is now, so he's in no rush. So I think what's happening now is that you're going to get more and more of that. Not just to avoid the entire hassle. Anyway, my only point is that the vast majority of the time, I think your doctor really has your best interests at heart, and there's a lot of other pressures. But that was just the one thing that, just to bring up. There's a lot of unnecessary imaging going on, that I can tell you.
Thank you.
Why can't they just put every test, every anesthesiologist, whatever it is, on one bill?
Well, you're going to be capitated.
I'm very...
No, not decapitated, capitated.
Both.
Capitated meaning that you're going to get what's happening with us at Jamaica Hospital.
Right.
We have been told you have 250,000 patients. If you don't see any of them, you get a certain amount of money. If you see all of them and you go over your budget, you're gonna get a certain amount of money.
I could see like 3 people though, and they'll send me 3 separate
I
bills.
don't know, I'm not involved, I don't.
No, but I'm just saying.
I don't know that, I talked to Stuart, he's the businessman.
Yeah, well, and that's a bigger question than I can answer. I mean, and not everyone does it that way, but
Nobody does it that way.
Right.
Nobody does it that way. Like,
I can't really
you
answer
can
that.
have one test and get like 5 bills afterwards. Oh, this person,
Someone
this
sees it
person,
as
this
as
one.
more than one.
Getting personal now too much.
Yes,
Question for Dr. Bright.
oh, good.
I have a question.
I have a lot more to say, something important to say, but go ahead.
For all of our, most of our lives, they've told us that, cardiac and people with not eating fats and how dangerous the fats are and everything else, and cholesterol. And now I'm hearing stuff in the last few weeks, months, about fats are good for you, and this cigar was here before.
Let me get into that,
Can-
quickly. What you're talking about is in terms of dietary fat eating.
Right.
For a long time, it was felt that eating cholesterol was not good for you. The reality is that the cholesterol in your body doesn't come from cholesterol that you eat, like in eggs, or butter for that matter. But the cholesterol in your body comes from saturated fats that you find in beef, that you find in pork, that you find in animal skins, that you find in whole milk, and so on. And that stuff is the stuff that's converted into lipids. But lipids alone aren't going to kill you unless you have the unusual condition of familial hypercholesterolemia where cholesterol is 500. It's usually a combination of things that get to you. And not everybody with a high cholesterol gets a heart attack. But we play odds. All we can do is play odds. But, yes,
Just a couple of weeks ago, they came out, they prefer that you drink whole milk rather than the skim milk. It's better for you.
Right,
I'd like to see the facts on that.
I heard that.
Okay. Because, never mind twice the calories. I have to say,
Forget the calories, they're not
The next break, I'll stop
Huh?
it. The next break, I'm gonna stop it.
Okay.
Children,
I gotta say a few things here that are really important.
Let's just stop it here.